Well, it's a great pleasure for me to be here today, and I want to thank Dr. Srivastava and the program committee for inviting me to talk to you about implementing outcome assessments in clinical practice. By way of disclosures, I'm very grateful for research support that I've received from Bayer and Baxter, and I sit on data safety committees for Novartis and Pfizer. Now, Dr. Srivastava posed a very challenging topic to me when he assigned me this talk, and it really forced me to reflect on my own personal practice. So I've been in the field of testing and developing outcome measures for over 20 years, but how do I actually use them myself in my own clinical practice? I'm a rheumatologist. In my ascites clinic, we do careful assessments of function and strength at every visit, and I use those assessments to guide my patient choices. I wonder how many of you do this. In my arthritis clinic, I give out a functional and quality of life questionnaire to every patient at every visit, which we store for future research, and I never even look at it. So I'm just going to ask for a show of hands here. How many of you treat or look after persons with hemophilia? And so that's many people in the audience. How many of you use routine measurement of outcomes, standardized measurements of outcome in your clinical practice day to day? So only a very few. Well, this is a map of my talk today, and I hope by the end of it I will have convinced you that implementing standardized outcome measures in our day-to-day routine clinical practice will lead to better outcomes, to better health for persons with hemophilia. I'm going to start by discussing in general what outcome measures are, and conceptually what we should be measuring, a brief discussion about generic versus disease-specific measures, and then look at the measures that we have currently available in hemophilia and discuss which ones we might use. I'll talk about what the evidence shows in terms of improving healthcare by using and implementing healthcare measures, talk about what we do, and finally end up by what's next. And as I say, I hope by the end of this, I will have convinced you that we should be implementing standardized outcome measures in our clinics. So let's start off by discussing what outcome measures are. Again, I've been in this field for over 20 years, and I never actually thought to define to myself what outcome measures are. I thought I knew, so I went to the literature, and I was gratified to find that what I thought outcome measures were is what's been most widely described. So, for example, Mosby's Medical Dictionary defines an outcome measure as a measure of the quality of medical care, the standard against which the end result of an intervention is assessed. And similarly, the New South Wales Health Outcomes Program defines an outcome measure as a change in the health of an individual, group of people or population, which is attributable to an intervention or series of interventions. So outcome measures are about testing whether our treatments or our interventions truly work. Now, why do we need to measure things? Lord Kelvin in the late 1800s put it this way. He said, when you cannot measure it, when you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. And that's led to this widely popular saying, you can't manage what you don't measure. Again, a show of hands. Has anybody heard this saying before? Yeah, many people. This is widely said in business, in economics, and in medicine. Now, if you're like me, and I imagine many of you are, you probably feel, I certainly feel, that I'm a very objective assessor about whether my patients are getting better. So, for example, if a young boy with hemophilia has a target joint and I start them on intensive therapy, I feel that I don't need any special measures to tell whether they're getting better or not. But in fact, as humans, we all suffer from a variety of cognitive biases and judgmental shortcuts or judgmental heuristics that often lead us to make poor decisions and see things that aren't actually there. And I would suggest for those of you who might be interested in this, that Daniel Kahneman, Israeli-American cognitive psychologist who won a Nobel Prize in economics for this work, has summarized in this beautiful book a lifetime's work about cognitive biases and judgmental heuristics in this book called Thinking Fast and Slow. Now, there's many different types of cognitive bias, but one that's very important for us in medicine is confirmation bias. We tend to see what we want to see. So everything that we look for, and all the ways that we perceive have a way of proving what we already believe, confirmation bias. And that's why you can't manage what you don't measure. Galileo put it this way. He said, count what is countable, measure what is measurable, what is not measurable, make measurable. Now, before I get carried away, an equally smart guy, Einstein, said, not everything that can be counted counts, and not everything that counts can be counted. So we shouldn't get too far carried away, but I think the message is here is if we can measure things, we should, because we'll be more objective and more accurate. So conceptually then, given that, what do we measure? Now, we're in the health game, so we're measuring health, and we've been helped in the last 60 years or so by the World Health Organization's definition of health. The World Health Organization says that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And 10 years ago, they gave us additional help in this area by the revision of their International Classification of Functioning, Disability, and Health, or the ICF model. Now, in the ICF model, a disease, and in our case, hemophilia, affects someone's health through three different domains: body functions and structures, which are anatomy and physiology, which in turn impact on our activities or our instrumental activities of daily life, those things that allow us to do what we need to do. And that in turn affects our participation in society, our interaction with the world. Now, in turn, there are environmental and personal factors that impact on these things. So, for example, environmental factors like wheelchair ramps. And when I think about personal factors, I'm reminded of two girls in my arthritis practice, the same age with the same degree of arthritis, one of whom misses most days of school because of pain, and the other who's captain of the basketball team. And different things are important to different people. And we must consider many perspectives when we think about what we should be measuring. So, for example, when we look at the care of children or adults with hemophilia, the doctor, the nurse, the physiatrist and physiotherapist, occupational therapist, social worker, psychologist, and their family all have different things that matter to them. And, of course, so does the patient. Now, while we talk about what are the kinds of things we should be measuring, there are three very important properties of outcome measures that we must consider. Those are reliability, validity, and responsiveness. Reliability meaning that if I apply the same measure twice to a patient that hasn't changed, or if you apply a measure and I apply a measure to the same patient, we get the same result. Validity means that we're measuring what we think we're measuring. And responsiveness, if you recall, we said that outcome measures are our way of telling whether there's been important change following a treatment. Responsiveness is, can that measure pick up clinically important changes? So reliability, validity, and responsiveness. With those considerations, I want to talk briefly about generic versus disease-specific measures. In research, generic measures have some advantages. So, for example, a number of generic health measures, like the Quality of Well-Being Scale, the SF, or short form 36, the SF-12, and the Sickness Impact Profile, have all been applied to patients with hemophilia. And they allow us to compare the impact of hemophilia with other conditions, for example, the impact of aging and chronic lung disease. However, in our clinic, they're less helpful. For example, those measures don't measure anything about bleeding or the impact of factor infusions. And so I would argue that for clinical care as opposed to research, we should be much more interested in disease-specific measures. And we have many. So, for example, in the area of health-related quality of life, for adults with hemophilia, we have the HemQual-A, the Hem-A-Qual, the Qual-Hemo, the Hemophilia Qual, and the Hemolatin Qual. For children, we have the HemoQual and the Chocolate, all of which have been studied and shown to have reliability and validity, and for the most part in clinical practice show responsiveness. So we have excellent disease-specific measures that we can use. So, which ones should we use? And in this case, I think that ICF model, the World Health Organization model, can be very helpful. When measuring the disease process itself, We have a number of traditional tools like factor levels and genetics, inhibitor testing, PK measurement, trough levels, things like that. But what about for the rest of the health package? We've had some help by the World Federation for Hemophilia, which is in its desire to come up with a core set of measures that we can apply for research studies and in the clinic, has developed the compendium of assessment tools. And this brief list appears on their website. Now, I know the website's changing, and there's been some revisions, but as of a few days ago, this website address was the right one to get you to the compendium. When we look at the different domains of health and try to think of what our compendium or core set might look like, we have many tools to look at body functions and structures, that is, anatomy and physiology. For instance, we have imaging tools. X-rays are widely used and widely applicable across the world, and we have reliable and valid scoring systems like the Arnold-Hilgartner score or the Pedersen score. MRI tests are becoming more widely available and very sensitive to changes in joint structure and function. And we have, for example, the International Prophylaxis Study Group, or the IPSG, quantitative score of MRIs. Ultrasound is becoming more widely available even than MRI, and it's easy and practical to do. And we know that power Doppler flow is a good and valid measure of synovitis. And the Toronto, Utrecht, and Valour study group have been working towards a quantitative score for ultrasound testing. So we have many scores that we can use that are disease-specific for imaging. For physical examination, we have a number of tools as well, including the Hemophilia Joint Health Score, which we've talked about at this meeting for the last several meetings. I'm just going to ask for a show of hands again. Who here is familiar with the Hemophilia Joint Health Score? So not everybody, so let me walk through this a little bit. It's a scored physical examination tool which looks at the ankles, knees, and elbows and scores them in the domains of swelling, duration of swelling, muscle atrophy, crepitus, flexion loss, extension loss, joint pain, strength, and gait. It's a very reliable tool. The first reliability paper was published by Pam Hilliard in 2006. It's since been studied in China and Brazil and shown to be highly reliable. The reliability coefficients I'm showing you here are the intra-class correlation coefficients. So that is the chance-corrected concordance. For example, if we flip two coins, we might end up with two heads by chance alone. This coefficient goes from 0, which is no agreement beyond chance, all the way up to 1, which is perfect agreement. Anything above 0.8 is considered to be almost perfect agreement. And you can see that between observers, the reliability is almost perfect. From test to test with the same observer, the reliability almost perfect. And within test, reliability, measured by the Cronbach's alpha, is very high. And it's also a valid score. We published these findings last year. This comes from a 5-center study, Stockholm, Denver, Montreal, Utrecht, and Toronto. We studied patients with hemophilia A or B, mild, moderate, or severe, and they were examined by a doctor and a physiotherapist blindly. We had 226 subjects in this study, the majority of whom, as expected, had hemophilia A, the majority of whom were severe, but in this setting were on lifelong prophylaxis, and only a few of whom had inhibitors. Because of the treatment, it's not surprising that the median lifelong number of joint bleeds was only 5, but it ranged between 0 and 150. And what we showed was that, in fact, the HJHS had very good validity as well as reliability. I'm showing you here correlation coefficients on the top line with the Hemophilia Joint Health Score, on the bottom line with the older World Federation Gilbert score. Between the scores and the physician-judged joint health, we had very good moderate correlations. Overall, arthropathy impact, very good correlations. And between the number of lifetime hemarthrosis, again, very good correlations, exactly as expected, proving construct validity. And the HJHS was highly sensitive, suggesting it's also not just reliable and valid, but also very responsive. This is the HJHS, the total score on the vertical axis. This is the Gilbert score. And these are mild, moderate, severe patients. Now recall, the severe patients were mostly treated with lifelong prophylaxis. And even so, the HJHS was able to sensitively distinguish between them about twice as well as the older World Federation score, suggesting that this is a very good disease-specific tool to use with our patients. Now, based on that study, we've made some revisions. We understood from factor analysis that the HJHS really examined 4 distinct aspects of joint health. That is functional impairment, synovitis, joint damage, and arthralgia. But there were 3 items, circled in red here, that had very high uniqueness factors, meaning that they didn't really work well with the rest of the scale. And so revisions have been made. We're now on the version 2.1, and an excellent video has just been developed showing people how to use the HJHS that's available within the next short while on the IPSG website for people who would like to use this in their clinics. Now, in the domain of activities, we have several disease-specific questionnaires that, again, demonstrate reliability, validity, and responsiveness. The group at the Christian Medical College in Vellore have published the Functional Independent Score in Hemophilia, the FISH, which is a performance-based instrument that measures activity limitation. That is, patients are observed doing instrumental activities of daily life and scored in terms of their level of impairment. The current FISH looks at eating and grooming, bathing, dressing, transfers to chairs and squatting, walking, stair climbing, and running. Now, it's recognized that in countries where there's a lot of factor available and prophylaxis is widely practiced, that many patients will score perfectly well on the FISH. And so the group in Vellore is considering developing an extended version of the FISH, the E-FISH, which will have more challenging activities included in it so that it can be used across the world in a variety of different settings. Now, the group in Utrecht took a different tact in looking at activity limitations, and they did something called the HAL, the Hemophilia Activities List, which is a self-report questionnaire that looks at different activities would normally be required during the day and asks patients to score for themselves how they fare. And Wim Groen in the same group published the pediatric version of it, the PED-HAL. Now, the HAL is an interesting questionnaire because on top of looking at instrumental activities of daily life, it also asks questions like playing with others, going out to movies and entertainment, being involved in team sports, things that have a social participation aspect to them. And that leads me to the measurement of participation. So we do have tools like the HALS and other quality of life tools that are disease-specific that have some aspects of participation measured, but I'd like to argue that we're not quite there yet for participation. Now, Ueda and Okawa, Japanese rehabilitation specialists who have been great thinkers in this area, published a paper in 2003 called The Subjective Dimension of Functioning. What is it and what is it for? Discussing this issue of social participation. And in it, they bring up a story of a golfer, and they say, if you cannot golf because of impairments or capacity limitations, but you've been a lifelong golfer, then that would be disastrous. However, if you're like me, and you never golfed anyways, then just being unable to golf isn't much of a big deal. This is a very subjective concept. And they argue that if we could add the missing subjective dimension to the ICF, it will become a really comprehensive classification of total human functioning and disability, and as such, it will provide a solid theoretical basis for more practical clinical tools, such as quality of life. Additionally, Hemmingsen and Jonsson, in the American Journal of Occupational Therapy a few years ago, published this paper called An Occupational Perspective on the Concept of Participation in the ICF, Some Critical Remarks, and they were critical indeed. The 2 points that they brought out were these. The first and probably most serious problem with the operationalization of participation in the ICF is the exclusion of the subjective experience of meaning. That is, if I've never golfed anyways, it doesn't matter to me. The second issue, related to the ICF definition of participation, regards the lack of emphasis on people's opportunities to influence their daily lives and make decisions about personal questions, which they call autonomy or autonomy of choice. So if I don't want to golf, then I shouldn't be penalized in any measure that asks whether I do golf. And so I think we have a ways to go with measures of social participation as it relates specifically to hemophilia. As well, we haven't yet developed very good disease-specific measures of environmental barriers or enablers or personal factors. We have many generic questionnaires that can look at things like self-esteem, self-efficacy, resiliency, and so forth. But we don't have these yet applied in a disease-specific manner, and maybe we don't need those. Maybe general questionnaires are good enough for measuring these aspects. We have a lot of questionnaires. We have a nice framework for deciding on it. Should we implement those outside of research in our clinical practice? Well, what does the evidence say? Much of the work in this area has been done in the UK, so I'm going to bring forth a few literature reviews that come from groups in the UK. The first was from 1996 from Greenall and Meadows, and their paper called The Effectiveness of the Use of Patient-Based Measures of Health in Routine Clinical Practice for Improving the Process and Outcomes of Patient Care. And what they did is they did a systematic review of all the controlled clinical trials that compared routine use of outcome measures to standard clinical care. At that point, they found 13 studies. Those studies measured things like the short form 36, the functional status questionnaire, the general health questionnaire, self-rating depression questionnaire, the symptom checklist, co-op charts, the screening for the impairment in the elderly, the Beck Depression Inventory, and a couple of arthritis scales, the Arthritis Impact Scale and the Health Assessment Questionnaire. And in those 13 controlled clinical trials, they found that doctors in general find implementing routine outcome measurements in their clinics to be useful, practical, and acceptable, that they did improve some processes of care, for instance, the improved detection of psychological and functional problems, but there was no evidence to that point that they actually improved health outcomes. This was followed up 10 years later by another group from the UK who reported, again, a systematic literature review, this time with 38 studies. And what they found in the mid-2000s was their paper indicated that feedback of patient-reported outcome measures in a routine basis to clinicians has a substantial positive impact on some of the processes of care, particularly the diagnosis and management of patient conditions. So that's good. But they also felt that evaluations of patient-reported outcome measures need to be far more thoughtfully designed to take account of the likely real-world contribution of instruments designed to enhance patient involvement. This thinking led Long and Dixon to propose that in addition to reliability, validity, and responsiveness, if we want to implement outcome measures outside of research, but in our routine clinical practice, they must also be feasible, have clinical utility, and be acceptable. A challenge for us as we move forward. Well, if that's what we should do, because it's going to improve our patients' health, if we should be implementing these various measures in our clinical care, what do we do? Well, when I asked for a show of hands earlier, only a very few of you said that you actually implement routine outcome measures in your clinical practice. I know in Canada, as part of the Association of Hemophilia Clinic Directors program, all the Canadian centres have adopted the HJHS, the Hemophilia Joint Health Scale, for the yearly clinical examination of hemophilia patients. I know that the group at the Christian Medical College in Vellore have published that they use routinely the Canadian Occupational Performance Measure and the FISH in their routine clinical practice, and it helps them with their clinical care. I'm going to ask for a show of hands again. Now, after hearing what I mean by outcome measures, who here does implement some type of routine outcome measure in their clinical practice? So we have a long ways to go. What's next? Well, I've suggested to you that the World Federation has already begun to put together a core set of clinically useful measures, the compendium of assessment tools. We're not all the way there, although these tools all have been shown to be reliable, valid, and responsive. We need to make sure that they're also feasible, useful in the clinic, and acceptable. I've also suggested that the literature has shown not in our field of hemophilia, but in other fields, that the routine use of standardized outcome measures gets us beyond our cognitive biases and improves our processes of care and the health of our patients. So I would put forward to you that the time is now to start to adopt these measures in our standard clinical practice. We've come all the way around the bend. We discussed at the beginning that outcome measures, the way that I've defined them, are tools that help us know whether our patients are responding correctly to our treatments. That conceptually, the World Health Organization has given us a way of thinking about health and the different dimensions of health that can help us choose which tools to use. I suggested that in clinical practice, as opposed to research, disease-specific measures would be more useful for us. And we've talked about some of them, especially in the areas of imaging, physical examination, and activity limitation. The evidence would suggest that these will help us in providing better care and improving the health outcomes of our patients. And we don't, as shown by that show of hands, we don't often do it yet. So what's next? I urge you all to go out, have a look at the compendium of tools, consider in your regular clinical practice implementing some of these standardized outcome measures. Thank you very much.